All right, I see a lot of people have had a chance to sign on today. So I would like to welcome everybody to the three-part webinar series on the global effort to reduce the burden of cervical cancer, hosted by the United States National Cancer Institute Center for Global Health and the Consortium of Universities in Global Health. I am Ann Rosich. I'm an associate professor in epidemiology at the Johns Hopkins School of Public Health. And my co-moderator for the webinar today is Dr. Isaac Adewole. He is currently a professor of OBGYN at the University of Ibadan and the former Nigerian Minister of Health. So I'm going to kick us off, and then Dr. Adewole will join us after our speakers to help moderate the question and answer session. I also have news to share that we understand the WHO will be sending out a formal communication today confirming adoption of the global strategy and associated resolution, which we had discussed on our previous webinar last Wednesday. So this is really a signal to all of us as advocates that we can share the good news and also start taking action. We will share the link to that announcement when we receive it, or you can check on the uicc.org webpage. We also expect a short video address from Dr. Tedros within the next few days. So we're happy to sort of share that breaking news with you guys today. This is our second webinar in the series, and today we're going to focus on the latest scientific advances, tools, and approaches to address the global cervical cancer control challenge. Our first speaker today will be Dr. Nicole Campos. She is a senior research scientist at the Center for Health Decision Science at the Harvard School of Public Health, and she'll be talking on the use of health decision modeling. Next, we'll have Dr. Mark Schiffman, a senior investigator at the United States National Cancer Institute, who will talk to us about new technologies and innovation in cervical cancer screening and treatment. And to close out our speaker panel today, we have Dr. Ophira Ginsberg, who is an associate professor at NYU and the director of the high-risk cancer genetics program at the Perlmutter Cancer Center. As I mentioned, after the three speakers, we will have a question and answer session. So I encourage you to please go ahead and submit your questions using the question section of your panel. That's on the right side of your screen. Please submit those as we go along so that we have time for Dr. Adewole to see those questions as he's going to moderate our final panel discussion at the end. Just one last thing is with regards to CME credits. These are available for today's webinar from Boston University. So if you've registered for credits, you'll receive an email about how to receive them. So with that, I would like to pass it over to our first speaker today, which is Dr. Nicole Campos, to have her kick off this webinar. Thank you.
Thank you, Dr. Rosich. Can you see my slides okay?
Great.
Anticipating the global health agenda in the coming months, when health systems will continue to grapple with COVID-19 and limited resources, it will be especially important for cervical cancer prevention programs to implement affordable and high value or cost-effective interventions. But no singular prospective study or randomized trial can evaluate all possible prevention strategies over a cohort's lifetime. Therefore, we will use health decision models to project the cost effectiveness of novel prevention strategies in the populations with the greatest burden of disease. It is imperative that the health decision models get it right, achieve scientific consensus, and prove to be trustworthy. When we talk about prevention strategies that we want to evaluate, a strategy consists of programmatic decisions to deliver preventive interventions over a woman's lifetime. Strategies will differ across populations depending on infrastructure and available resources. Any number of strategies can compete against each other in a health decision analysis, well beyond what would be feasible to evaluate in the short time span of a demonstration or research project. For HPV vaccination, key policy questions will include the ages at which to vaccinate, the number of doses to administer, and how to deliver the vaccine in order to reach high coverage levels. For screening, the critical questions include what age range to screen, what screening and triage tests to use, what are the relevant referral thresholds for these tests and for treatment, and how screening will be delivered, such as provider versus self-collection of samples and the number of required visits in a screening episode and so on. Given the complexity and the number of possible strategies, we can see why health decision models are necessary. Furthermore, due to the typically long interval between acquisition of HPV infection and cervical cancer, to address important prevention policy questions, health decision models are really the only tools designed to consider the lifetime natural history of HPV and the pathogenesis of cervical cancer and the estimated long-term impact of prevention strategies. Elements of screening programs in lower resource settings include screening with low-cost HPV tests with self-collection of specimens to promote greater uptake and safety in the COVID era in particular, triage of screen-positive women to identify those at highest risk through HPV genotyping and or automated visual evaluation, or AVE, which Dr. Schiffman will be speaking more on shortly. Treatment of precancer with thermoablation for eligible women, otherwise LEAP for women whose transformation zone is not fully visible or accessible for ablation. And we note that it's this treatment part that is really the essential part of prevention, not just screening itself. And Dr. Ginsburg will be speaking more on this shortly. Health decision models can help identify whether and how these elements can be integrated to form cost-effective strategies for a particular population set of values and resource constraints. These health state transition models must be based on the causal pathway of cervical carcinogenesis. Past and current models have relied on cytologic or histologic classifications to define stages on the causal pathway to cervical cancer. Current models tend to require progression through CIN1, CIN2, and CIN3. These classification systems have served a useful purpose in helping us to arrive at the true HPV-based causal pathway, but we argue that to continue to rely on these systems to define health states in health decision models will result in disease misclassification. Increasingly, the new screening technologies that are identifying early signs of transformative infections prior to the detectability of histologic CIN2 or CIN3, health decision models will need to consider the associations between test performance in different populations and predictors of true precancer, such as HPV genotype, duration of infection, and age. By getting rid of misclassification in the health decision models, we arrive at this simplified multi-stage causal pathway of cervical carcinogenesis, and we use this as the basis for a new health decision modeling framework. The fundamental natural history pathway is known to include the following necessary stages in the development of cervical cancer. First, acquisition of a carcinogenic or high-risk HPV type. Second, viral persistence as opposed to viral clearance. Third, progression to precancer, which we define as persistent lesions with a high likelihood of invasion if left untreated. And finally, invasion. This schematic represents the new state transition model of the causal pathway. Each box in this schematic represents one of the necessary stages on the path to cervical cancer, and each arrow represents the risk of transitioning between stages. We can identify who has an HPV infection based on simple and reliable tests. The challenge for building cost-effective screening programs is to correctly identify women with precancer without overtreating all women who have high-risk HPV. We consider this model to reflect the universal natural history of HPV infection and cervical cancer. However, there are at least 3 distinct natural history patterns that are observed globally. The stages in cervical carcinogenesis are the same across these patterns, but the probabilities of transitioning between stages are distinct, as signaled by the differences in HPV prevalence patterns across the lifespan, which we believe are linked to different levels of immunologic control of HPV infections. On the top left of this slide, immunocompetent populations are characterized by lower HPV prevalence in mid-adult women between the ages of 25 and 49 years when screening is optimal. This pattern is characteristic of much of the Americas, Europe, and parts of Asia. On the top right of the slide, partially immunodeficient populations that do not have a high burden of HIV but appear to have reduced cell-mediated immunity, for instance, due to chronic parasitoses, show higher HPV prevalence at optimal screening ages. And this pattern is characteristic particularly in sub-Saharan Africa. On the bottom of the slide is an example of HPV prevalence in HIV-infected women with pronounced immunodeficiency in controlling HPV infections, leading to continuous high prevalence across screening ages. We recognize that there may be more of a continuum of populations based on HPV prevalence, with some populations falling somewhere in between the lower and higher HPV prevalence settings. And also some higher HPV prevalence populations may represent a mix of women with and without HIV infection. And we are currently exploring data across geographical settings and populations to determine how different transition risks contribute to these different HPV prevalence curves. Most of what we know regarding HPV acquisition, clearance, and progression to precancer, that is, those natural history transitions that are critical to informing the multi-stage model of cervical carcinogenesis, comes from lower HPV prevalence settings where HPV-16 dominates the causal pathway. In these settings, if persistent high-risk HPV is present in mid-adult women, there's a reasonable probability of precancer. It's unclear whether the high prevalence of high-risk HPV in many sub-Saharan African populations is associated with a proportionate risk of precancer. Our goal is to directly estimate transition risks as much as possible to reduce uncertainty and guesswork in the state transition models. We need more data on transition risks from settings with higher HPV prevalence and from HIV-infected women to inform health decision models for these populations. In particular, data on HPV progression to precancer by HPV type and time since infection are very limited. Given the dearth of longitudinal cohorts in these settings, we're exploring cross-sectional and other data sets for indications of differences in the transition risk from infection to precancer. Data on the probability of invasion are also very limited in all settings, as this transition is not observable for ethical reasons. And this transition risk will need to be indirectly estimated through model fitting processes. As I mentioned earlier, the new modeling framework will evaluate the use of AVE as a triage test to determine which high-risk HPV positive women receive treatment. The cost effectiveness of a triage test for high-risk HPV positive women in a given setting will hinge on how much it can reduce the costs and the burden of overtreatment while still accurately identifying women at high risk of precancer. And just to reiterate, it is absolutely essential that the health decision models account for population differences and transition risks in order to provide valid policy conclusions. To summarize, health decision models are the only tool that can project cost effectiveness over the lifetime. To provide valid cost effectiveness results, these models must be based on the multi-stage causal pathway of cervical carcinogenesis, which is universal, and transition risks, which we think vary by population HPV prevalence pattern. We're in the process of updating the health decision models to account for potential differences in HPV epidemiology in the highest burden settings. These models will then be used to evaluate novel prevention strategies in different contexts to demonstrate whether these can in fact reduce screening costs and improve screening effectiveness. Transition risks for higher HPV prevalent settings and women living with HIV are urgently needed to inform valid health decision analyses. So thank you very much. And with that, I will turn things over to my colleague, Dr. Mark Schiffman of the U.S. National Cancer Institute.
Hello. I'm going to be giving more slides so that you can keep them, and please feel free to contact if you want to discuss any of them. But I have just a few minutes to describe a sampler of some new tools that we can use for accelerating cervical cancer control. We have no economic or PI we have no conflict of interest. And I want to acknowledge my collaborators. So the point is, we all know the situation, we all know what we want to achieve, but we're lagging behind in our scientific knowledge application to the tools we're actually using. So when we project what we can do to control cervical cancer, we are using the resources that from the past. No one anticipated that COVID-19 would tend to accentuate the disparities that we're so much trying to address. But now everything's going to have to get even more difficult and thoughtful. We need to keep people safe in order to screen, because screening is elective, and we have to use tools that are accurate while being even more economical than we had thought before. So of course, we think we will get control of this pandemic, but what I'm saying is we must also take into account COVID. We can't ignore it. So there's a time lag concern. If we use just the tools that were already approved, we will anticipate very, very long time to control. And so what about considering right around the corner new technology? We can't be overly optimistic and think that we're going to have an antiviral that'll be really a penny and very easy to use. On the other hand, there is a series of new technologies that I think are going to be reasonably high probability optimistic options, and that I want to talk about a couple of them. So I'm not going to repeat any of this, but if we use the correct model and we describe that HPV is early and then precancer is the next wave and cancer comes after that, and we want to interrupt it, then we have interventions that have to be appropriate to what Dr. Campos described. So we know this, and I'm leaving these slides for discussion later, but we're arriving at this sense that we're going to be doing something about vaccination, which I'm very hopeful will eventually be shown to be one-dose vaccination at some early age, and then an effective screen once or twice in a lifetime that is both accurate and affordable, that leads to a treatment that can be done without huge amount of resources. I'm not going to talk much about thermoablation, which is now approved, but that seems to be where I can see replacing cryo and is coming up as a very good option for a lot of people. So we're going to be using this kind of a model, and I'm going to talk about one promising control strategy. If we hope that one-dose HPV vaccine protects long enough and that we have a high valency, perhaps with some kind of cross protection or an adjuvant that allows it to take care of the onset of HPV, then we're going to be talking about screening that provides reassurance to most women. Now, we're very intrigued with LAMP, for example, right now. It's just an example of something, isothermal loop mediated amplification, which is an isothermal PCR, real-time PCR, and it gives extended type groups. It gives you something about the kind of type you have, and it can be done you certainly can find the high viral load ones within 20 minutes. And it's somewhere around $5. So we're very interested in the fact that it can work on a self-sample. And in a way, we're thinking that self-sampling will soon, in the whole world, be the COVID appropriate first screening method of using a sensitive HPV test on a self-sample as the way to reassure most people while only bringing in those with high-risk HPV for triage. HPV is common, even of the high-risk types. We need triage. So what we've come up with is just one method. It's something we call automated visual evaluation. There's other names for it, but basically it's a deep learning algorithm that gives on a cell phone type, smartphone type image taken by a health worker, a confidence score for whether that HPV positivity represents simple infection, likely to go away, or precancer. And if there is precancer, thermal ablation is feasible for many people. And if not, only a very few people need excision. This is represented for your going over it later in a figure that I show you. We're working in a large group collaboratively with many people to work out these algorithms that will all go on smartphone and will be given to a health worker so that we can triage the HPV positive woman, or it can be done if there's no HPV by itself, albeit not as accurately as if you combine it with HPV. Now, what are the types that need to be considered? I'm a big proponent for knowing the type that somebody has. I think, as Dr. Campos said, that the actual situation is due to which type and how long it's been there. So we believe that HPV 16, then 1845, then the HPV 16 related types can be distinguished from the bottom types, which have very low risk. And this is from DeMarco et al. Look at this, call me or text me if you want to talk more about it. But I think these are real and important types to know. Then the automated visual evaluation. There's a lovely article in JAMA, just came out, describing deep learning. I won't go over it. Time is so short, but we're all going to need to know about deep learning because it brings competence and expertise and it can be put on a cell phone or a device and make sure there's a standardization of different classifications such as precancer or not. And so I put this up for your study and but it works very, very well, and you can make it work. So if you get enough truth, you can make the difficult calls that we all need to make about distinguishing how severe something is, and that's difficult for anyone. And in fact, we get very good results, but the harder thing is to make sure it goes onto a simple digital capture device, and that fine tuning is going to take a lot of images, and we know it'll succeed if we get enough, but the COVID pandemic has stopped us. But these are the kind of images you can get from smartphones, and they're very comparable to colposcopes. And the limitation is just the number of pictures you need to train something in artificial intelligence. It's a matter of big data. So, so far, our real performance in triage is only moderate. We need more images. And so because we need more images, and because everything works best if we have collaboration, we invite you for validation and dissemination for basically join us for a common public health effort in line with the announced wonderful news about the endorsement of the elimination goals. And we invite for people who want to join us in this attempt to do public health related new technologies and for the good of everybody, keep things going despite COVID. Okay, now I'm going to pass this on to my colleague, Dr. Ginsberg from NYU.
Thanks so much, Dr. Schiffman. I'm going to speak a little bit about beyond technology. So after hearing all the exciting, or some of it, the exciting developments happening on the technical side, we need to ask ourselves what exactly is possible to reach these aspirational goals. So what will it take to reach elimination targets in any country? And I'll just start by saying, kind of the obvious, but it was so important what Dr. Schiffman just said about COVID pandemic is that first, we really must do no harm. We have to conceptualize what it will take if we're going to bring people in for a mass screening campaign, for example. It obviously doesn't make sense to do that at the moment in that classical strategy. So we need to start and end with the women at risk. Ensure we consider all the aspects. What are the needs and preferences of the women? What matters to them? And consider the whole picture along the entire cancer screening journey. Now, this includes the question about equitable access to affordable, high-quality health services, not just for pre-cancer, but also for invasive cancer. What do we know about the ability to access radiotherapy and high-quality surgery, chemo, and palliative care as well? And so this brings me to a concept that was passed in a resolution, another resolution of the World Health Assembly in 2016, which was on people-centered health services, which really means putting people and communities, not the diseases, at the center of the health system. And it speaks to the need for empowering people to take charge of their own health HPV self-sampling is actually an excellent example of that. And there are others. And evidence shows, of course, when we look at the community's needs, health services can be more cost effective and lead to their ability to respond better to health crises. And of course, we're unfortunately in one now. Not a lot of time to go through this, but just to say on the website for WHO and people-centered health services, there's the vision for all people to have equal access to quality health services that are co-produced. And I think that's a key here, talking about the community engaged practices and research. And you're going to hear a lot more about that with Dr. Rosich and her session next time on implementation research. Okay, so back to the future. We're going to go back to the 1970s and think about what was happening at that time. And my reference point for everything is always music. And so we think some good, some bad, whatever, depends on what you think, and some very aspirational. And here is 1973 and Mr. Marty Cooper, who is the inventor of the cell phone. And you can see in the right panel how much smaller these have ultimately gotten over time. Obviously, that's not even up to date. And that brings us to the Digital Health Resolution in 2018 at the 71st World Health Assembly that talked about the spread of digital technology, global interconnectedness, and the potential for member states, and that's pretty much all of us, to achieve universal health coverage, et cetera, ensuring access to high quality care. So let's talk for a moment about mHealth and how this might play a role as another type of technology in cervical cancer elimination. The short version of the definition here is the use of mobile wireless devices for public health. But if you look up to an earlier version, just in 2011, which is not that long ago, kind of feels like a million years, but it's not, it mentioned personal digital advice assistants, or PDAs, which many people listening now may not even know what that is. So there's been a lot of progress. And in fact, according to the ITU, the International Telecommunications Union, in 2015, there were 7 billion mobile phone subscriptions, and 70% of these were in low and middle income countries. And in many countries, more people have access to phones than they do to clean water, a bank account, or electricity. And I understand that for some people, they may think, my goodness, that shows how far along mobile technology has come. But in fact, I think it also reminds us that many people still don't have access to clean water, a bank account, or electricity. So we need to be realistic about what is achievable on the ground. So how do we do that? Well, so far, governments have actually found it challenging to scale up and integrate these mHealth solutions. A lot of pilot studies. Dr. Marlene Temmerman, I believe it was, in the last session in this series mentioned pilotitis, which is a problem. So how do we connect the dots here, and how do we make things scalable? So again, WHO released a guideline last year on digital health interventions. No time to go into detail, but just to mention, the interventions are for health system strengthening, right? Not for any one disease, not for health care service delivery only, but for strengthening the whole health system, which I think many of us would argue is what is needed in order to achieve the aspirational targets of the global cervical cancer elimination strategy. So here we can see there are some guidance regarding clients, so patients or clients who are undergoing cervical cancer screening. You can target health promotion, education, countering myths and stigma. Many ways to do this between health workers, and here is clinical decision support, which Dr. Schiffman just mentioned in regards to how the ADE and other similar types of machine learning or deep learning algorithms can be used actually in the service of improving health quality and efficiency, and perhaps also cost effectiveness. The other I will mention here that's often, in my view, under considered is the referral pathways, coordination, communication, tracking, and in some ways patient navigation, so that women who are found to have a more advanced lesion, who are not amenable for cryotherapy, can actually reach the services they need, and they can be supported throughout the care pathway. We can also look at supply chain management, facility, interfacility communication when supplies are running short, to attend back to the procurement pathway for the necessary equipment, et cetera, for cervical cancer elimination, obviously other health concerns. Then we have the WHO MERA checklist, which is about evidence-based reporting. Obviously no time to go into detail, but I would encourage you to look at this paper from BMJ in 2016. and highlight three things here. One is interoperability. At the moment, my colleagues and I, Dr. Karen Yates at Queen's University in Canada and other team members are looking into, for several countries, whether our mHealth application, which I'll touch upon just at the end, actually has the not the capability, but what is the situation on the ground in the countries of interest, and what have they been able to do thus far, which compatibility into their health information system or their HMIS system. Here we have contextual adaptability. Is this appropriate for this setting? What would be the messaging? Is it usable, etc.? And of course, data security and compliance with national guidelines and regulatory statutes. So is there such a digital health guidance regarding cervical cancer? There is, and that's the Be Healthy, Be Mobile, which is collaboration between WHO and the ITU on cervical cancer. And just a couple of words about a project that I'm involved in with Dr. Yates, Dr. Zach Mtema in Tanzania and colleagues, Dr. Safina Yuma in the Ministry of Health in Tanzania, is something called CVIA, which is smartphone enhanced visual assessment. It began actually to help support quality assurance and training with supportive supervision model for nurse providers performing visual inspection with acetic acid with VIA in the national CCAP program. But in fact, it can also be used to assess the cervix for women who are HPV positive. And there's many other types of functions, programs like ours, platforms like ours can use. Ours is cloud-based. We want everything to be shareable, et cetera, in terms of the technology, not obviously the data itself. And we had a pilot study, which we published. Again, the importance of publishing everything we do, including, the good, bad, ugly, the difficulties. And we've just 2 weeks ago published our sort of final assessment of the first 10,000 women screened for this smartphone enhanced training, quality assurance, monitoring and evaluation model. And you'll see opportunities and challenges. So we need to be honest about what we're doing. And I'll end with a word of caution. Technology alone is really never the solution to complex systems challenges, and health and certainly the elimination of cervical cancer does represent a complex challenge. As much as we know the technology is largely available, there are still complexities to actually reaching those targets. So beware of the hype, look for demand evidence, and also we should ask ourselves, is there a low-tech or even a non-tech intervention that might work just as well? Is it cost-effective? Is it affordable? And does it serve the needs of the women that we're trying to help? Thanks very much. And I'll pass over now to Dr. Adewole, who will moderate our Q&A. Thank you.
Thank you, Dr. Greensburg, for that presentation. I also want to thank all the three panelists for doing justice to the topic. I have one question now, and I think it can go to any of the panelists. That question is, why is HPV DNA testing the only cited screening method? Is it because it has the highest sensitivity and specificity compared to other methods?
The reason I
okay.
This is Mark Schiffman. The reason I like self-sampled HPV is because quickly you can reassure the large majority of people without any worry about, you can hand out the swab safely and collect it safely. And if acceptable locally, for the great majority of people that you don't need a speculum examination to initiate screening. It also has the highest prognostic negative predictive value. It reassures the longest. We've done studies up to 15 years, and it has good predictive value, 5 to 10 years at least, if it's negative. So depending on the age and the setting. So it is a very powerful way to reassure. Its disadvantage is it always requires a triage, unless you're willing to accept treating a lot of people. So, but combined with a triage test, it can be very accurate if you are in a place where you can only do a screen a couple of times in a lifetime.
Thank you, Mark. Question 2. I think this will also go to you. You recommend HPV screening for low and middle income countries. Please, could you specify the name, manufacturer, and price of an HPV test that is affordable to ordinary women in LMICs? And also said you acknowledge in 2017 that no such test exists. They also quoted your reference in response to human papilloma screening for low and middle income countries as an affordable test come to the market. Mark.
We are doing I'm the principal investigator of something called Accelerating Cervical Cancer Control from the NCI. And we've been trying to devote ourselves to exactly that point, that there really wasn't an affordable and accurate test. I believe that there is strong promise to what I called LAMP, which is a isothermal, meaning it doesn't require heat cycles, so it can have simple equipment, real-time PCR. And there are several companies coming forward with technologies like that. I don't mean to say that they're the only ones, and I was trying to stay away from any. I have no commercial interest in any particular group, but I ask people to look for the validations coming out of that technology class, because there's several companies, and of course it'd be important to have competition. The price is $5 now, $5 per test. The cost for the triage that always needs to go with HPV will be the cost of the phone, because all of the artificial intelligence stuff is openware that we're doing just for public health good. So certainly we want to make this in the dollars, we certainly want it to be as inexpensive as possible and keep driving the price down. That's the point of the foundations interested, like the Unitate funded foundations and the Gates funded foundations. Certainly the whole notion is affordability, and that's where we're headed.
Thank you, Mark. The third question is to Nicole. Thanks, Nicole, for walking us through the model assumptions. Can you clarify the model assumes one cycle of screening for HPV negative clients and for HPV positive, but have negative? They also exit screening regardless of HIV status. Let me go through it again. Can you clarify the model assumes one cycle of screening for HPV negative clients and for HPV positive, but automated visual evaluation negative? They also exit screening regardless of HIV status.
Yes, thank you. So the model doesn't have to assume any particular screening frequency. It's flexible enough to look at different screening protocols and very specific screening algorithms in different settings. So we would look at, depending on a different settings resource level, like how many screens per lifetime, given a budget and given the willingness to pay in dollars to save a year of life, what the particular algorithms would be. So it's flexible in that way. The example that I gave for AVE was that if a woman is high-risk HPV positive, then she could be triaged to the clinic for a pelvic exam, at which point AVE could be done. So we're narrowing the number of women who would need to be seen after a positive high-risk HPV test to only see those at the clinic who have already been shown to be at higher risk because of the presence of a high-risk HPV infection. And for women who are high-risk HPV negative, they wouldn't need to be seen again at that point, but we could evaluate how valuable it is to screen them again in their lifetime 5 or 10 years later.
Thank you, Nicole. This is to Ophira. Based on your experience, what are the biggest barriers to scaling up digital interventions?
Thank you. That's a very good question. I think some of them were summarized in the slide regarding the MERA checklist, and I know these slides will be available, but I would suggest that it's really getting from the pilot to any kind of transition to scale And I think one of the barriers exists because, as on the implementation research side, sometimes we haven't done enough to ensure that what we're doing makes sense in the system that we're working within. And to have those conversations upfront and early, especially regarding what's called the HMIS interoperability. This is something that is essential, really, in order to get something scaled much larger. In the Tanzania project, we were able to do a lot of scale-up work, that possibly because the primary strategy we have is in training and training of trainers with humans using the phone rather than something that's just an automated data capture technology. I hope that partly addresses your question, if not fully.
Well, I think you've done justice to it. Let me throw this open. Can one have CIN 1, 2, and 3 in one transformation zone? Another question says, can you have 1, 2, and 3 in the same patient? And I think this is the same question.
Absolutely. In fact, commonly, when we do microdissection, which we've done, and for that exact question, you often find in the same cervix what you would call an HPV infection, and then a precancer, and then areas that look almost normal. But typically, if there is HPV production, then there is a microscopic lesion that would be called possibly CIN1, but then there can be an equivocal, which is a CIN2, and or a definite high-grade CIN3. It's clonal, and we always just talk about the highest grade one as what is typifying the woman. But those terms, CIN1, 2, and 3, I would maintain are obsolete for really defining the way we need to think of things. I think we need to think in terms of the HPV infection and its state.
Thank you, Mark. Let me throw this to Ophira or Nicole. Management of countrywide screening programs will likely demand strong information systems to allow proper case management and follow-up. Would not this be a major bottleneck to be addressed to a community benefit?
If I may, if I understand the question correctly, the person asking wants to know what the regarding a barrier to uptake within for a countrywide national strategy. Okay.
Yep.
Again, I guess I would come back to the conversations that need to happen between ministries, for one thing, right? So the Ministry of Health, if there is a Ministry of Information Technology or Communications, and certainly a telecommunications organization and regulatory body, those conversations actually have to take place in order to ensure that what is being trialed can be ultimately adapted and adopted within the country's CCAP or National Cervical Cancer Program. Ideally, it also will engage, will offer an opportunity to create a screening registry. And that's something that IARC also has tools for in the IARC screening platform that's now available online. And I hope that answers the question.
Okay. I suspect this question might go to Mark. I'm developing a program in Uganda, and we are trying to implement the VI assisted with digital cervicography. How do we learn about your program?
We welcome anyone to join in the community to help improve it for everybody. At the end of my slide set, I think I give Sylvia de San Jose and my email, and we will answer anybody who joins us. We're very eager to make this a large community of learners for everybody's benefit. We welcome everyone, no matter what your level of engagement might be. There is no company here. It's all just us trying to make it better and do something together. So we welcome everyone, and we'll put you on a list if you're just interested. If you have images, if you have certain things that we can help, please just let us know.
I have another question, and I think I'll throw it open. How can we best address regulatory of new HPV DNA assays? There are certainly a plethora of emerging platforms on which LAMP assays can be implemented. But all we face issues with getting WHO pre-clearance, etc., etc.
That is a major issue because it costs so much money to bring a new test that if it's going to be very, very inexpensive to spend in the United States, for example, $30 million to get it approved is not possible. It's not consistent with low cost. So I don't really know the answer to that exactly. So that's something for a longer discussion.
Let me throw this to Nicole or ablative therapy suggests that you have lower HPV prevalence in 1 year compared to a watchful waiting approach. Do you have treatment of HPV either through benefit?
I believe I caught that question. I think you were talking, you froze, but I believe that the question was talking about watchful waiting versus universal treatment of HPV positives. And that is certainly a individual depending on the amount of true follow-up. It is frustrating when you see in guidelines come back in a year if you think that the reality is that you'll lose many, many people. And we face this issue a lot. So that's where I believe that HPV typing or type grouping is very important. There's a big difference between having an HPV 16 and having a type 68. And that if you're using a test that lumps them together, you're in trouble. But if you can do some risk stratification based on what are the worst types, at least you have a chance of making an intelligent choice on treat now versus wait.
Thank you, panelists. I have another question. To what degree should we be concerned that relying on self-sampling as a primary first screen for everyone will result in other conditions being diagnosed later or missed because of a potential reduction in interactions with healthcare providers? Will Ophira want to tackle this?
Sure, thank you. Again, that's a very important question, and particularly now regarding the COVID pandemic, when people aren't coming for care with actual symptoms and signs of health conditions, including cancer. So just to set that aside for a moment, I believe that it's still very much worthwhile in the era of when we have HPV self-sampling available more widely. Women ultimately, first of all, should have a choice whether they wish to do that at home truly and send it in by whatever mechanism, or indeed want to come into a clinical setting and have it done there. And there are surveys that have been done in a number of countries indicating that, again, women's choice and preferences are really critical here. Not everybody feels comfortable doing what they call a medical test at home. So putting that aside, there is always a risk of things going virtual, depending on the reason, precluding or maybe creating a perception that people aren't expected to come in for healthcare when they need it. I think that comes back to communication and community engaged health promotion, so they understand what the signs and symptoms are of something that could be another sexually transmitted infection or indeed a cervical lesion, etc.
Thank you. This is to Mark. Excited to hear these developments on LAMP and AVE. What is your personal estimate as to when we will have these developments at the front line?
Our initiative was initially a 5-year initiative, and we're in the start of the 2nd year. We wanted to dovetail it with the WHO call for elimination. COVID has thrown that, like many of our dreams, personal and public health, into delay. I have no idea is the answer, because it takes a lot of images to train an accurate algorithm. So that's why we want cooperation. Since this is a cooperative thing, if people have images stored of any kind of the cervix linked to truth as to what it is, the faster we get together and organize, the faster the artificial intelligence will work, as well as your Google or some other Google image or to recognize people on the web. The more images, the faster it goes. The more we organize ourselves, the faster it goes. We had campaigns that we were hoping to get hundreds of thousands of screens in the next year or two. They aren't going to happen in the hundreds of thousands. We're going to have to rely on a slower pace in order to keep people safe and not assemble into big crowds. And so I welcome everybody to try to do this as fast as we can.
Thank you, Mark. I think you are also in a position to address the next question. Which HPV test is priced at US $5? Which manufacturer? There's a lot of interest in low-cost HPV tests.
You know, when I signed up for this, I was asked whether I'd be talking about individual commercial assays. If you want to contact me, I'm not like trying to avoid the question permanently. Just give us a call or email me, and we'll discuss the options. There isn't a single test, but there are tests at that we really can get down to that level already. They have to be even cheaper than that eventually. That's the price today. The price has to be lower even than that. So let's talk about what those tests are. And there's already competitors in that space, which is very good. And I'd have no endorsement of any particular test. It's very important that we not rely on a single monopoly of any kind.
There is a question that is a bit ambiguous from Walter. Please elucidate on the concept of HPV. I don't know what that means, but I wouldn't want to know if any of the panelists will want to say about that. It's just too vague. So Walter may want to refine the question. But let me go to the next one. How close are we to having a one-dose HPV vaccine? I guess it's not a matter of the vaccine, but as a matter of policy. Nicole or Fira?
Dr. Campos?
Yeah, so I think Mark can actually speak to this too, because NCI is doing one of the large trials in Costa Rica right now, the Escudo study, to look at one-dose vaccination. So I'll let Dr. Schiffman speak to that, and there are several other studies, and there's some cohort evidence that one dose is effective. So we're making some early guesses that are informed assumptions that will be sort of the way forward, but I'll let Dr. Schiffman speak more to that.
The unmasking of that trial is in the 3-year range, somewhere 3 years from now, to get truly definitive information. I refer people to Dr. Amy Kramer at NCI, or Dr. Alan Hildesheim, or Rolando Herrero. This is a Gates NCI study. There are other studies being conducted in Africa, and preliminary evidence from follow-up of people who got one dose still shows continued protection at the decade level. And so we're very hopeful that this trial is going to give the evidence necessary for regulatory action for one dose. And then there's also new vaccine coming with maybe more types, maybe adjuvants. We don't know, but it's going to keep getting better, and all looks good about the chances. So I'm hopeful for that.
Thank you. Somebody is asking for your email address, but that actually was displayed on the last slide. That's Mark. I think your last slide had your email address on.
Yes.
So, and then this,
just look me up.
Okay.
Look me up, or look any of us up.
Okay.
Right.
Then this is on acceptability of digital technology. The question is, what about the acceptability of digital technologies among healthcare workers? Ophira or Nicole?
Well, digital technology is actually a lot in much wider use informally than people might realize. For example, as we're going through this process in several countries now, asking about, going through a checklist, in fact, asking people how they use. If you ask them if they use digital technology or mHealth, they might say no. But then you ask a provider, like I did with some nurse midwives recently in West Africa, do you sometimes use your phone to SMS text your patient that she needs to come back or with a result of a test? And they said, oh yes, we do that. And in fact, do you use that between providers sometimes to see where a patient might be at, perhaps if she's referred somewhere? And they say, certainly we do that. The acceptability in most studies is actually very high. And in our own study, it was extremely high. There was really not much not much of a barrier whatsoever. Questions also need to be asked regarding acceptability to the public, and that is, of course, a separate but related important question, including consenting for their information to be stored, even in de-identified, et cetera, if you're using cloud-based servers, et cetera. So that's an important question.
May I say also that all of our technology is meant to be assistive. Nobody trusts just looking at an algorithm from artificial intelligence and just trusting it blindly. In the early days, as we're becoming familiar with it, it's meant to assist the judgment of the health worker, not replace it.
There's also some tests showing that providers actually feel more confident when they're using technology than when they're not. That's in like studies where we've actually done RCTs, where the same information, even if it's just information gathering or a structured interview, with or without a smartphone.
There are one or two questions about pricing. And the first question is that HPV prices are difficult. The price the manufacturer states are really acceptable because they do not factor in custom duty and so on. The other question says transparency in pricing will be a tremendous advance in implementation of elimination goals. So Mark, how do we scale the order of pricing, custom tariffs, and ensuring transparency?
These are very important, real questions. And certainly we don't want to rely on any technology that then gets amped up in price. And this has happened to us personally before. A public health tool that's then resold at 10 times its actual cost. So it has so many implications, that question, that it stops me from trying to have a simple answer. But I don't have a simple answer for that. I do know that for the triage thing that we're doing with the phone, we are making sure there's no, that it's going to be extremely inexpensive to and supported at a foundational level. In terms of the HPV test, that is still small companies, and I agree, that's going to really have to be a pressure to keep the prices down, hopefully through fierce competition.
This question is actually a very common question we encounter regularly when we try to do screening worldwide. How will you address concerns about ability to screen for cervical cancers without adequate access to effective treatment? Much like diagnosing problem with capacity to treat is not ethical.
We all agree. It's
Correct.
the treatment that's essential. Any plan to screen without effective plans to carry it through to treatment is unethical. And I think everyone here agrees that that has to be handled. Thermoablation goes part of the way, but better tools need to be developed, and all the way down to treatment and palliation. So otherwise, don't start, because it's not right. So
I'll just sort of make a comment here, because this is exactly the same note I think that we ended our first webinar on, is sort of reaching an agreement about the necessity and the ethics of coupling treatment to screening. Since we're reaching our time here, I thought it was, again, a really good point to end our webinar on. I'm going to make one administrative announcement, and then I'll pass it over to Dr. Adewole to have any final words and to do our final goodbyes. But I do want to give everybody a reminder for our third and final webinar, which is going to be the exact same time next week. So that is going to be next Wednesday, the 12th at 11 a.m. Standard Eastern Time. The focus of that will be ensuring effective implementation of cervical cancer prevention and control strategies. So starting to think about how we can use these new tools and technologies in real world practices. And we're going to have 3 speakers as well. So we encourage everybody to stick with us for the final webinar. And Dr. Adewole, to you to sort of close out this webinar.
Thank you, Anne. I think what is left for me is to thank the panelists, Nicole Campbell, Mark Schiffman, and Ophira Ginsburg for doing justice to the topic and for sharing knowledge, not only with us, but with attendees at this important webinar. I also want to thank my co-moderator for giving time to the NCI and CUGH. I want to say thank you, and thank you for advancing knowledge towards elimination of cervical cancer. Thank you. Have a wonderful day.
Stay well.